You will agree with me, whether it's poverty, whether it's violence. And as public mental health practitioners would say, the problems have been described now, and we know they are problems. And I think the challenge for us is, are we going to continue to describe the problem of mental health and the limited gap in care? When will we stop and doing something about it? And I think that's why we are here today to keep thinking about the solutions towards addressing the main social determinants of mental health. And in our legal space in Eldoret, we are going to present a very brief uh, presentation on a pilot project that we are to address this treatment gap. Like Professor Madan has already begun telling us about what they are doing here in school. So this is a peer-delivered community-based intervention, problem-based therapy. Dr. We heard about interpersonal therapy. There are many therapies. I want to problem-solving therapy. And as I start, I want to say this one. The project is called Position. Position is involved the youth, and it is funded by the Clinical and Translational Science Institute, Indiana University, as part of what we call reciprocal innovation grants. So these are the small grants, these grants that they give to do work that can both be done in Kenya and in the US. And so you must collaborate with a team from the US so that hopefully after you implement it here, can also be implemented back in the US. So as you can see, we are working with a team from Indiana University. Actually, Matthew and Shropia is the PI and it work, and the rest of us are just collaborators, and we have members from Duke University, Moi University, and number of us working on this. So why we talk about problem solving therapy for youth especially? And you'll agree with me that a lot of mental illness has onset early in life. Actually, if you look at the figures and facts, we probably say that up to 75% of most mental illness will begin by the 24 years of age. That's quite young. And unfortunately, the youth are also going to benefit the transition to other. And now, if you add all the other issues like unemployment and violence and big things happening, then we know that early is best in terms of intervention, prevention, and promotion. And it's also true that there are some interventions that cut across whatever problem you have. You know that you think about the youth, there's some depression, there's substance use, there's some anxiety, there are all those issues. And one of the thoughts is, are there interventions that can cut across? So that it doesn't matter whether you have depression or you have substance use. And problem solving therapy is actually one of those interventions that cut across. And why problem solving therapy again is that it is also quite simple. And if you think about it, even in real life, sometimes you talk to people and they tell you have many problems, and they're not able to define exactly what they're going through. And one of the thoughts around this intervention is that people need to be encouraged to call their problems by name. And in problem solving therapy, don't say they have many problems. You actually list it. I have financial problems, I have a loan, I have relationship problems, I have conflict with my mother, I have problems with school, especially for young people. And so it's simple and starts with defining whatever it is that someone is going through, then helping people think through. So what? They have financial problems, but what would I do about it? Because it's not enough that you have a problem in your finances, but you're trying to sit down and think about some of the options that you have. And the other thing is, if you think about financial challenges, it's that of the huge problem. Then they need to come up and say, I have a financial problems and these are the options. I can sell charcoal, I can take on a job at a restaurant. Very simple, again, thinking about what option one. Because if then you are, I don't know what is the distance, estate in Sumu, but in where you come from, they have airport view in inside and complexes like that in the other end. So if you have to sell charcoal in airport view, then people might not buy it. But if you're living in a different estate, that's not possible. So picking the most feasible solution given the circumstance. And then there's commitment to implement. So I have decided that it's going to be charcoal selling. And I've decided that I need people that what we don't use charcoal, maybe they are neighbors. Testing after the post tested, they usually will be the workers who work with those who might use charcoal. So I might go there, implement it, and follow up and evaluate it. And that is why it has been shown that it can control. And the other important aspect of problem solving is a review. So I decided to set up to solve my financial problems. After 3 months, can I come back and say, since I started setting it up, my problems are reducing. And so problem solving has been seen to be simple and easily implemented, even if you have not gone through this psychiatry training, you can actually do it. So this position project, then, at the core of which is problem solving therapy, aims what? One, it aims to establish if this problem solving therapy can actually be delivered in a setting, in a community setting within Uasin County. And so we're going to pilot this, and the problem solving therapy was going to be delivered by peers. If you've been working with youth, you know that sometimes, if you are being older, the youth feel like you don't get it because we belong to the other generation. And the question is, if a youth who understands the circumstances deliver this intervention by teaching, help the fellow youth help solve their own problem. So that's what we're trying to do. And while at it, also have the youth who are delivering problem solving therapy intervention also get to screen youth for common mental illness. So we have different tools. We have the strength and difficulties questionnaire. We have youth talk problem. We have the PH9 and we have done 7. So again, youth training youth to screen and then to see whether preliminary efficacy can be demonstrated and feasibility and hopefully even acceptability. So those are the objectives of this pilot study. And where it's been done, so again, our thinking is community. And I know we have complex institutions like where I work, a national referral hospital. And then unfortunately, you don't always feel very comfortable coming to such institutions. So within Eldoret town, we have the Family Health Workforce Kenya, which is a setting that has mostly focused on reproductive health and other issues that affect the youth. And they have a center. So what we did is that we actually set up a structure and give the Eldoret because youth are comfortable in coming to that setting. Then we thought that's the best place for the youth to go there after they've done their dance and everything they do. Then they're able to interact with the peers who are working on the mental. What kind of study is it? Mixed methods, implementation science also that we thought that we will, of course, when you screen, then you have quantitative data on how many of the youth have some certain mental health issues. Also, there's a lot of qualitative work that we're going to evaluate the acceptability and feasibility. In a pilot study, actually the sample size is small, which is just about 40 youth. Of course, the hope is to screen more and get at least 40 who can get enrolled into the sessions. And of course, conveniently support among the youth and attending that there are no activities that they accept. And so far, the project is ongoing. And one of the things that we did initially is to adapt. So the PSC is manualized. And we got one of the manuals that was done in India, and it was implemented in a school setting. So we actually got to adapt that manual and then to recruit the youths, and the youth we are targeting were 12 to 18 years, and then have the training for peers. These peers were 18 to 24. The reason why the peers are not very young, so you actually would call it year peers, is because for the ones who are delivering, they are engaged in a contract of some sort. And if you are engaged in a contract, you must be an adult. That is what we need, which so that's why the ones delivered in the PSC are 18 to 24, but the target will be 20 to 18. So there was a recruitment and training, and how do we recruit? We actually recruited from the youth who are already, there's a lot of activities happening that it's okay. So we actually took some of the ones who already volunteering and work on reproductive health in other aspects of whatever is happening and depending around there. And then after recruitment, of course, there's the delivery of the 5 sessions, or it's a 5-session intervention. And like we say, stepwise again, the first time you get the youth is able to discuss to the mentioned called the youth talk problem. So the youth is actually asked to list their problems, all of them, and then they list the top 3 and then identify the one during this 5 sessions they feel urgently needs to be addressed. And that's the one they work with the peer counselor for the 5 sessions. And then there's follow-up. Remember we did depression, the strength and difficulties questionnaire, we did that 7, and there's follow-up on the same during the 1 month and during the 1 month and 6 months after the initiation of PST. And of course, one of the things, if you look at lower down, there's the qualitative interviews that is still pending. But we have already managed to do the first, other than the qualitative interviews and the data analysis, we've actually been able to recruit the youth into the PST and follow up for 1 month, 6 months already. So just to mention about the adaptation, how did we do it? And I know there are complex frameworks that have been mentioned about how you adapt tools. And we use the cultural adaptation and contextualization for implementation framework. I'm sure you will this, you'll find it. There are several steps, about 10, where you determine this is the tool that you're going to use, and then look at it and decide whether it works. And the most important aspect of those 10 steps is ensuring that we're involving the youth because it is for the youth. And if you look at the tool, when we withdrew from India, we actually made 135 changes to the tool. A very important aspect of the tool is that we are not just taking tools out there because India we might be similar but quite different in many ways. So you really need to make sure that you are contextualizing. And I have 5 minutes and we finish. Training, again, how did we do this training? 2 weeks. About 8 hours put in, and the most important aspect of the training is role play. And we are learning, especially in implementation science, that it's not enough to come show up and give a lecture. Very important that we do a lot of role play and observe the youth actually doing the PSC, just to make sure that they are actually doing it right because of fidelity. And so far, what we can say, so how do we analyze the competency? So after training, it's very important that you evaluate that actually they get it. And one of the tools that we use is working with children, assessment of competence tool. And I'm sure many of us might be familiar with the NAPT. And there are several tools that are used when you train on psychotherapeutic interventions to evaluate competency. And a scale of 1 to 4, and from what we saw, at least where it's not great, but you can see there's a change. From initial 2.29 scores before training, there was an increase to 3.1. And again, we also did pre and post tests. And you can see the changes in scores. And just emphasizing the need, as we do these dimensions, we need to make sure that we're testing that is changing knowledge, that we're not just training and giving people certificates. And we have really go home and say they have been trained to have ways of doing this. So, what have we done so far? At least you can see that we have been put 182 youth at the FHOK, and now we have been able to enroll at least 46 have already gone through the PSC. And this is work that is ongoing, but what we can see here from, at least from what we have done so far, is that one, at least the youth can be trained. And the other important thing that is feasible to actually implement it within a community setting, and we are hoping, because really we know that there must be evidence-based. For this, we don't need a pilot study. It was just to demonstrate feasibility, and the hope is that after we are done, we can actually do a full-scale randomized controlled trial, so that when we say truly, peers can be used to deliver problem-solving therapy that 21. That's where we hope to go, and we look forward to coming to appraise you on the ICT communication. I'm sure even some of the partners that we did here. So if you're interested in this kind of work, yes, we're happy to partner so that you can do it. And as I finish, I want to appreciate the opportunity that has been given to us to demonstrate that PST has potential to make a difference. And as you can see, there are many partners that have come. So I want to thank you very much. And I'm glad that we questions. Thank you.